Hello, everyone. Thank you for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. Since the beginning of this pandemic, I've been hosting Facebook Live here every Friday, 1 p.m. Eastern Time, bringing experts from all over the world to share with us their latest research, their work, and all topics that are relevant to our community of premature babies and parents. And today we're going to talk about Neonatal Abstinence Syndrome. We're going to discuss the importance of prenatal, perinatal, and follow-up of mothers and babies where moms have used drugs or alcohol during the pregnancy, highlighting the importance of harm reduction, supporting women and families, not punishing, and looking at the outcomes related to the social determinants of health. We will touch on the principles of neonatal abstinence syndrome and the newer concept of roaming in, eat, sleep, console, and some new medical approaches to care. I have here with me today Dr. Sarah Gander, a pediatrician from St. John, New Brunswick, who is also the clinical and academic department head of Pediatrics. She's faculty at Dalhousie and Memorial University and co-founded the New Brunswick Social Pediatrics Research Program. Her research interests include the social determinants of health, neonatal abstinence syndrome, and hepatitis C. She recently launched a site for the Parent-Child Assistance Program, which advocates and supports women who disclose substance use in pregnancy. She's also the clinical lead of a clinical program designed to serve children in difficult living circumstances, particularly aimed at breaking cycles of generational poverty. Dr. Gander, thank you so much for joining us here today. What a pleasure to talk to you and learn much more about this topic that is so very important for our community.
Oh, thank you for having me.
So I know you have a little presentation to share with us. I will let you share the screen right now, and I would encourage all of you watching us here today to send your questions and your comments that can address after her presentation.
Okay, so everybody can hear me okay?
Yes.
So thanks for having me today. It's 2:00 in the afternoon in St. John, New Brunswick, Canada, and I'm glad to be able to speak with you today. The presentation will be fairly short and sweet, and hopefully we'll have some engagement with questions to dive a little deeper. So just again, I had a very nice bio there, so thank you very much for that. But just so you know, I am by training a general pediatrician. For the past 12 years here in New Brunswick. I went to medical school at Memorial University and did my residency at Queen's University in Kingston. And as was mentioned, I'm involved with research specifically around the Parent-Child Assistance Program, which we'll talk about more in the presentation. It's important to just say out loud that opioid use in particular is a pretty widespread challenge for Canada and the rest of the world. We really have seen the use stay pretty stable with our population for over the last few years, but are seeing the increasing amount of overdoses and opioid-related deaths, as you can see, increasing. And so when we're talking about neonatal abstinence syndrome, most people do default to opioids as being the substance by which babies are withdrawing from, because that's kind of the typical construct of neonatal abstinence syndrome. But withdrawal is not just from opioids, and not everyone discloses their substance use during pregnancy. So I think addressing this topic just as a broad concept, we need to entertain the fact that potentially any baby born could have symptoms that are related to some sort of withdrawal, because I think any of us in practice now would recognize that we see some withdrawal symptoms from SSRI use, so antidepressant and anti-anxiolytic use. Most of us have seen withdrawal symptoms from heavy smokers during pregnancy, and many people are on prescribed medication and using them appropriately, that we may need to be aware of some withdrawal symptoms that could happen in the baby. So I mention opioid use here because when you read about neonatal abstinence syndrome, we tend to go to the people who are using drugs or go to people who are on methadone therapy and or other opioid substitution therapies like Suboxone. But really, we need to keep our mind broad with this. And and this is not a problem that's going away. So I trained 15 years ago in Kingston, and when you train in Kingston, Ontario as a resident, you often go to Ottawa to see to spend some time in a bigger hospital. And I remember going to a lecture for our residency group, and it was on neonatal abstinence syndrome. And the speaker said, you may see a couple of these in your career. And working in Kingston, we were admitting a couple a week. And then here in St. John, I mean, almost every night we have some sort of encounter with a woman who either has disclosed use during pregnancy or a baby who is exhibiting withdrawal symptoms. So sometimes it depends where you live, what you see. But overall, 1,850 babies were born. This is data from 2016, 2017, were born in Canada that met the criteria for neonatal abstinence syndrome. And that was up almost 30% from just 4 or 5 years prior. And so I think many of us talk about the wave of the opioid epidemic, west to east in Canada. And we definitely saw an increase in the fallout of that with our babies. So what is neonatal abstinence syndrome? And so really it is just a set of criteria that are based on interacting with the baby with their central nervous system. So that would be things like people usually know about tremors or even seizures with withdrawal, gastrointestinal. Many people will think about diarrhea or very loose bowel movements, and even respiratory distress, so breathing really fast. And so there are different criteria that are used. And so we're going to talk about the Finnegan score, which up until very recently and still in most places is really the criteria that we use to diagnose neonatal abstinence syndrome. And we usually monitor babies for about the first 5 to 7 days. But in fact, there are many reports that show the effects of withdrawal well into the first year of life. And as a general pediatrician who, yes, sees babies as soon as they come out, but also gets consults for babies well into their first year of life and beyond, it's so fascinating how we rarely talk about those delayed symptoms when, say, I would get a consult for a baby at 2 months of age for diarrhea or 2 months of age for, say, jitteriness. I've learned now to ask a lot more detail about the pregnancy and any exposures that might have happened. But really those 2 times tend to be felt as to be very separate. And I would argue they're a very important part of the continuum. So this purposely is foggy, so you don't get caught trying to get into all the words, but it's really to illustrate the complexity of the Finnegan score. Now, if you read this, you would see things like, loose bowel movements or tremors, and you're meant to score them on a range. But I'm sure you could appreciate that that range is very subjective. So maybe you were taught how to use that. Maybe you have lots of experience with it. Maybe you have many babies to compare to, or maybe you're brand new and this is your first time using it. But this score has some serious consequences. Based on this score, we'll decide whether or not a baby, say, needs treatment for their NAS. And so that might mean an admission to the NICU, an IV, being put on morphine treatment or whatever the clinician decides. And so this subjective score has come under a bit of scrutiny because people sort of think, well, we hear in our hospital sometimes when they're out on the floor, their scores are high. When they come into the NICU, they're scored lower. And there's a whole bunch of reasons for that have to do with inter-rater reliability. So do people score the same? But also, and we're going to get to this, do babies score lower in different environments or higher in different environments? It wasn't until I was putting together this presentation and I wrote, "So you scored high," that I realized the irony of that word. But the high score of a Finnegan, so we're taught that if you have 3 scores of 8 or above, or a score as high as 12 on one assessment, that really you need to be reassessed and considered for treatment. And anybody on the call who's ever even had a smidgen of type of withdrawal in their life, maybe you've quit cigarettes, maybe you just are trying to avoid the leftover Halloween candy, or maybe you've had some serious addiction issues, you know how uncomfortable it is to be into withdrawal. And so, if you're used to having a steady flow of methadone for the 9 months of your existence, it is extremely uncomfortable. And so we don't like to wait until it's dire to treat a baby. But at the same time, it's a big deal. You're separating the baby from their parents. But then also they're often put into a quieter room in the NICU. They really encourage a lot of snuggling and skin time with the parents, but it may also mean some medication. And so sometimes scores are lower in the NICU, not just because the nurses are different, but because now they're sort of tucked into an environment where maybe we can see the fallout of that rooming in, which we're going to talk about. So I have this slide here about the golden hour. And the golden hour for me is really what gave birth, pardon the pun, to a lot of my work in the community and research with this population. And it really came from having my own babies and seeing your baby's face for the first time and having that experience and really thinking to yourself, I just don't believe that there's a human being that can be in this moment and not want to do the very best for that child, regardless of what their life circumstances at that moment, regardless of all the other business going on in their life. And that moment when you give birth and that you have that baby in your arms, I really felt was that opportune moment to engage a population which is sometimes challenging to engage. And so that's really why we built a lot of this. And so when we talk about rooming in, it was so intuitive to me. And I was so proud of being part of the Canadian Pediatric Society when they really emphasized the data that said, it's important to keep babies with their moms. And, there was a time when any baby at risk for withdrawal was automatically admitted to the NICU for observation. And we've moved away from that a bit. But how beautiful to think that, of course, babies should be with their parents and have that skin time and have that bonding. And if you're more interested in health systems and financial responsibility, a baby who's admitted to the NICU for opioid withdrawal in the data on average stays in hospital 15 days. And we can drastically decrease the length of stay of babies by keeping them with their moms, with their dads in the room if they're there, and really just looking at that rooming in. And then, I mentioned the Finnegan Scores, which was a bit subjective, a bit cumbersome, and, we've dealt with over the years. But then some smart people decided that, well, really, it's about eating and sleeping, and can they be consoled? And so the paper is, you'll appreciate the ESC, which is, the abbreviation for escape. It's, can we escape this mantra of looking at a score and not just looking at the patient themselves? And so is the infant able to eat? Do they sleep? If they are upset, which would be normal, can they be consoled in a reasonable length of time? And if they can meet all these things, then maybe they don't need treatment. And so, but if they don't and they need to be reassessed, we can start intervention. And now the world of intervention opportunities have far surpassed the, I'm going to admit you to the NICU for this 6-week-long morphine therapy that's going to take forever to wean down. There's lots of conversations about different medications, clonidine, methadone even some interesting oral treatments while the baby stays with the mom on the ward. Even at-home treatments, which is really fascinating and obviously comes with a lot of checks and balances, but very interesting stuff on the horizon. So just to give you an idea of why I really came to care about this topic so much, St. John, New Brunswick is named to, well, in the 2016 census, was tied with Toronto for the highest child poverty rate in Canada. Now, lots of communities, talk about that, but in St. John in particular, we deal with a lot of generational poverty. We're a port town. We have a lot of drugs. And so we have a little bit of data that was picked up where all the women in our catchment area can only go to one hospital to have their babies. And we ask them some questions when they come. So of about 2,300 pregnancies a year, 120 reported illicit drug use. I don't love the word illicit, so report drug use that is unprescribed. 6 underwent detox therapy during their pregnancy. Interestingly, only 13 reported alcohol use. And so I'd be curious in the audience what people think of that, because I think that would be a drastic underestimate. And interestingly, we have 5 methadone or opioid substitution therapy clinics in St. John. And at any one time, they say that they have about 5 to 7 pregnant clients. And most of the women who have used drugs in pregnancy or are in this group really talk about the negative stigma and lack of trust in the systems. I've heard stories, everything from, women being in a cesarean section room and hearing the nurse say, double glove girls, she has hepatitis C, to just being treated poorly, just that stigmatizing way. And then there are poverty-associated barriers, if that's an added complexity, where, it's difficult to get a hold of patients sometimes if they change their number quite a bit. The number one thing we have found in our research has been the lack of stable housing, and then even transportation issues, particularly after the baby is born, when it's difficult to get out. A lot of the services, whether it be, OBGYN services to mental health services to pediatric services to counseling services, all work in isolation and don't do a good job of talking to each other. And frankly, I think we all know that if you're worried about getting food on the table or whether or not you're going to get evicted out of your apartment, that's really top of mind, as opposed to trying to find a way to lift themselves out of poverty. Or really focus on some of the extras. So when we developed our research program, it was really in the wake of a lot of promising practice across the country. In Washington State, there's this brilliant program that's been around for 30 years, which is the Parent-Child Assistance Program, born out of the need for the fetal alcohol exposure population, which, 30 years ago, which evolved into, cocaine, which evolved into opioids and pills, and evolved into fentanyl, and now just kind of keeps reinventing itself depending on sort of the drug du jour, but all having the common thread of those families needing a lot of supportive coordination and communication. And I would really like to emphasize that harm reduction approach, because a lot of organizations who try to support these families with best of intentions are really looking for a more abstinence-based approach. And that is so challenging. And so, sometimes it is even, well, could we use fewer drugs or less of it? Or, what could we avoid and how can we get to at least a better place at this time? And so that, I think, builds a lot more trust. And really the end game is growing healthier babies, helping families, really kind of breaking this intergenerational poverty cycle, which is ridden with toxic stress and trauma. I didn't in this presentation get into adverse childhood experiences, but when people use drugs, we really talk about why do they use drugs? And it's really not just because. It's when you look at their lives and their histories, it's often a symptom of very many years of toxic stress and trauma in their own lives. And that is true almost across the board. So we developed this PCAP program in St. John as a satellite site from Washington. And the expected outcomes in the Washington data, which, like I said, has been going on for years, is that 91%, so the program is 3 years long. You have case management support, and it's really, if you will, I like to think of it as sort of like a Grammy or an auntie approach. So, lots of our patients have social workers, lots of them have workers for this, that, or the other thing, but their PCAP advocate is really meant to be their person, their unmandated person. And after 3 years in the program, 91% had completed some measure of substance treatment or were in progress. 78% were in fact abstinent from alcohol or drugs. Over half were attending or completing a GED. In Canada, that's your high school diploma equivalent, or were in some sort of college or work training program. And almost 80% were actually living with their own families, and so had gotten to a point where reunification with their children, which is a large goal for a lot of our ladies, having their kids back if they've been put into foster care or whatnot. So that was a big plus. And the message from women at the end is really that they were treated with dignity and respect, and that it's never too late to support and not punish folks who, are the mothers of these children. And then how can we really look to include them in the lives of these children that I see in my practice every day. So that is a little brief about neonatal abstinence syndrome and a few of our strategies and a few of the innovative programs that I think are happening in Canada and North America. This is our website if you're interested in finding out any more info or asking questions. And I'll just stop sharing my screen so we can see if there's any questions from the audience.
Okay, Dr. Gander, thank you so much for your presentation. It was very enlightening, very educational, and I think the step number one is for us as society to not, as you said, punish or judge, because we don't know the history of the families and why they end up where they are at the moment. So this is a beautiful work, and I congratulate you to step up and take this program, and I hope it serves as an example to the rest of our country. So thank you for that. So my first question to you is, when you first hear about neonatal abstinence syndrome, you think about the drugs, and we also mentioned that it's always prescribed medications such as Valium or Prozac that we hear. There's so many people on those medications these days. So for moms who get pregnant and are using this kind of prescribed medications, what are the recommendations, or how are they treated? You mentioned detox during pregnancy, but is this a program throughout the pregnancy that they go through, or how is the process there?
Well, I think when we're counseling moms about their medication use that are prescribed, particularly antidepressants and anti-anxiolytics, the mantra is really, if that's a medication that you need, we need you to also be mentally healthy during your pregnancy. And I mean, there are physical consequences to using those medications during pregnancy too. One that comes to mind is a slightly higher increased risk of structural heart disease. And so we don't want people to necessarily stop their medication if that's something they need and it's been prescribed for them. But I think the beauty of the rooming in and some of these eat, sleep, console approaches is that how reassuring to a mom to say, you know what, most of the time, if we keep the baby with you and you cuddle nice with good skin to skin and we keep the lights low, we just work on feeding and really those eat, sleep, console principles, the chance of a baby like that meeting a criteria to go into the NICU is a lot lower than, say, a woman who's on particularly a high dose of methadone, plus or minus other drugs that they've sourced on the street or prescribed.
So what about the moms who not disclose whether they are using the drugs or prescribed medications?
Yeah, so it's always so fascinating, right? Because why in the world would you disclose that if you know the fallout, if you know the fallout of it? And so, these are resilient folks, right? And they know the system. And so that has happened where, you get a consult to see a baby for a lot of symptoms that are aligned with a withdrawal type syndrome. And then you sort of, if you really are a motivational type interviewer where you can build some trust, sometimes you learn all of a sudden, oh yeah, actually I did use substances during pregnancy, or even I am on methadone and I just didn't tell them that when I came on to labor and delivery. Then hopefully again, our approaches are starting to change where, you just treat people with respect. And again, that golden hour and that time when women are in hospital is such an opportune moment to engage them to do their very best. Because there's a lot of their external influences are kind of taken out of the picture for at least a short period of time. And again, it's not as soon as they have symptoms, you're ripping them away and taking them to the NICU. It's built a lot of trust to say, okay, fine, this is what you can do to support your baby, and we'll come back and reassess, and that kind of stuff it's starting to turn the tides and make really empower women to be able to do what's intuitive, right? Cuddle your baby, keep the lights low, feed them, that kind of stuff.
Okay, we have a question from our live audience. First of all, she said, thank you, interesting. What do you suggest for babies in the NICU with neonatal abstinence syndrome whose parents are not very present? It can be difficult to care for these babies who need attention, and you are taking care of other babies too.
I know. That is our hospital started, this is of course pre-COVID, we're in a bit of a pickle now, but started a volunteer snuggling program. That's been very successful. And we've seen, we haven't run the data on that, but how like even the scoring or how the maybe length of stay would be a good measure, or dosage, weaning protocols of any treatment related to how much they kind of get snuggled by the nurses or the volunteers. And in our hospital, we tend to find ourselves sometimes one of the neonatologists likes to take a little break and sometimes snuggle the babies herself. So I think anybody can do some of that good stuff. It's not really skin to skin when it's a volunteer, but it's at least that warm body and the soft voices and stuff. This is a lot of the reason why the parent-child assistance program is so important to me, because as soon as women are discharged from hospital and kind of go back to their world, one mom said to me, okay, you're just going to throw me back to the wolves now. Just really the barriers for them to come were very difficult. And so it's always nice to meet these women prior, if you can, to them having their delivery and having a bit of a plan for that. Getting social work involved, obviously, for transportation help. At my hospital, the visiting hours, again, pre-COVID, were not very strict. And so it wasn't that you had to come at a certain period of time, which can be difficult. But I think it's just recognizing that we need to meet people where they are. And so, people need to go for smoke breaks. They need to go get their methadone. They need to do all of these sorts of things, and just not judging them for that and working around them a little bit is ideal to get them engaged. But then otherwise, I think we all just love on the babies when we can.
Yeah, so we have another question here. For the babies, if you need to start medications, what is your first drug of choice? And did you use quinidine? Sorry if I mispronounced, if you used quinidine before.
Yeah, so we actually have a huge task force right now in our hospital to really go through the research and develop a nice sort of protocol policy statement in our hospital using some alternatives. So up until this point, the only two drugs to my knowledge that have been used in our institution are morphine and clonidine. And so, but you're absolutely right. There's much more second, third, fourth line options, including oral medications and including medications that can be prescribed at home, like I said. So I have never used that, but I'm always interested in what people's experiences are, because again, you're trying to find the puzzle piece that fits for that individual patient rather than just treating them all the same.
Absolutely. So now we talk about Eat, Sleep, Console. The first question is, how is this approach being taken in Canada? Where are we at with that approach? And also the parents who are in this new approach, are they encouraged to breastfeed their babies?
Oh, great question. So in terms of the Eat, Sleep, Console, I'm a very active member of the Canadian Pediatric Society, and we talk about this quite a bit. And so I think there are quite a few institutions now who have either fully transitioned to the I was going to say eat, pray, like eat, pray, love, Eat, Sleep, Console. That book's been out for a while. Why did that come into my head? Eat, Sleep, Console approach. And many institutions are looking at pilot projects and how that transition would be made. Within New Brunswick, I have to say I'm very proud of the health network that I work in, because they're very interested in what works and what's evidence-based. And so we have 2 sites now that are piloting the Eat, Sleep, Console. And you may just think like it's so intuitive, just flip to it. But if anybody's involved in health systems, they know that change needs a bit of management. And so we're kind of working through that now. But our goal, I think, is to get there, because the evidence is pretty promising. Your second question was breastfeeding. And so I'm very much a pro breastfeeding advocate. When people can. Of course, there's all the reasons why it's challenging, and that's fine. I think the big sticky point that we're in right now is the majority of our population, at least that we know uses drugs that are not prescribed, are also marijuana users. And there's a lot of conflicting data over whether or not it's a good idea to breastfeed while smoking marijuana. And again, taking a harm reduction approach, is the benefit of breastfeeding outweigh the harm potential for marijuana exposure? I think we could have a pretty interesting debate about that. So for me, in the interest of wanting to encourage bonding, and the majority of my women either don't have a house that they're going home to, let alone a place to heat up a bottle, or don't have the money for formula, even though we have some nice social programs for that. Sometimes the harm of not breastfeeding outweighs the harm of a bit of marijuana use for me. But that's, again, all of these conversations are so individual.
Absolutely. And let's talk about long term. What happened to those babies long term in their life?
Yeah, so great question, because look at fetal alcohol syndrome. We know a lot about that. So we know a lot about alcohol exposure in pregnancy, what it looks like, how it, what the fallout of it is. We have good diagnostic criteria for that. And then when you look at some of the studies around opioid exposure or other exposures, the data is just not that good. And so, and it's not for lack of effort. People are trying to do that work. Some of the work is actually showing that it doesn't have that much of an impact, which is fascinating, right? Because we're like, well, intuitively, that can't be good for a developing brain. But there's so many other components to that problem, right? Like who traditionally would use a lot of drugs? Well, like I've already described, women who have had a lot of trauma, women who have mental health issues, women who live in poverty. Not always. That's the stigma, but it's a confounding variable in trying to collect that data. So that's actually my next phase of research. I'm working with this population during the perinatal time, but I'll be very interested to follow this cohort of babies throughout and try to nail some of those perspective pieces down for sure.
Absolutely. Then you have to bring you back for that.
Well, it's interesting, right? Because people are always talking about, moms, like anybody who deals with moms who say are on methadone treatment. It's always, oh, I want to decrease my dose, or I want to get off methadone during the pregnancy. And it's like, no. You get what you need so you don't feel like you're at risk for, say, a slip or what have you. And we all know that the dose of methadone increases during pregnancy. And so it would be nice to be able to give women some nice data that say maybe dose doesn't matter, or, it's more important to have them not go withdrawal in utero, like really some nice numbers for that. And there's a lot of people working on that.
All right, that's wonderful, Dr. Gander. Thank you so much for joining us here today.
It's my pleasure.
I will definitely bring you back, because you have a lot to talk about, and it's such an interesting topic. And I feel that we really, to keep this conversation going, number one, to end the stigma and to accept and embrace those families in the hospital, no matter what. And then how can we help them? So thank you for doing all this work. was lovely chatting with you today.
Okay, thank you.
Thank you. And thank you everyone for watching us here today. Next week is World Prematurity Day, and we have a very special week ahead of us. I'll be hosting Preemie Power Week, an international series of Facebook Live, which is also going to be streamed on our YouTube channel. We have 18 speakers from all over the world. We're going to be talking about parental presence in the NICU, during the pandemic and beyond, and so much more. All the information is available on our website. Registration is free. The events are going to be every day from 12 p.m. Eastern time here on Facebook. So I hope you all have a great weekend, and I see you on Monday. Thank you.